Welcome back to the deep dive. Today, we are cracking open one of the most critical clinical syndromes you will ever encounter, heart failure.
And right away, we have to be clear, we're not talking about a sudden heart attack.
No, not at all. This is a chronic progressive process.
Exactly. Heart failure, or HF, is a structural or a functional impairment of the heart's ability to fill with or eject blood.
Okay, so if you need that one high-yield definition to hold on to, what is it?
It's this. The heart can no longer provide enough cardiac output for what the body needs metabolically, or it only manages to do so by using dangerously high filling pressures.
And that leads to congestion.
That's the key. That leads to congestion.
So that really lays out the two core problems that are, well, bundled together in almost every single case of HF. Our sources really hammer this home. If you get these two pillars, you've pretty much mastered the syndrome.
Yeah, our mission today is to give you that clear blueprint. We need to unpack the two fundamental problems. First, there's congestion, which is backward failure.
And the other?
And then there's low perfusion, or forward failure. And then we have to connect that to how the heart's actual structure, the mechanics of it, dictates which one dominates.
Right, and how the body's own attempts to fix the problem, just make everything worse over time.
That's the whole tragedy of it.
So if you're looking to really get a deep, functional understanding of this condition, stick with us. This is all about putting the structure, the physiology, and the clinical signs together into one clear picture.
Let's do it.
All right, let's start with that first big distinction, forward versus backward failure. The sources have this great analogy, the ultimate traffic jam. Can you walk us through that?
Yeah, it's a perfect way to visualize it.
Yeah.
So think of your entire circulatory system as a huge city. The heart is the pump in the center, pushing all the traffic, the blood out to the suburbs, which are your organs.
Okay, makes sense.
Heart failure means there's a huge bottleneck. Traffic flow is just stuck.
So if the traffic can't get out of the city, that's forward failure.
Precisely. Forward failure means low perfusion. Not enough blood is getting to where it needs to go. And the effects are, they can be subtle at first, but they're really severe.
Like what?
Well, your muscles get fatigued, your brain might feel a little sluggish or confused, and critically, the kidneys notice. They sense that blood pressure and flow are dropping.
And that's where the problem really starts to spiral, right? Because if the kidneys sense low flow, they're going to try and fix it.
They're going to try and fix it by holding on to salt and water to boost the volume in the system.
But that just makes the traffic jam, the congestion, so much worse.
Makes it so much worse. That's backward failure. The attempt to fix low flow ends up flooding the system. That's the traffic backing up, way past the city limits.
So let's talk about that flooding, starting on the left side of the heart.
Okay. So if the left ventricle can't pump the blood out, the pressure inside it starts to rise. That's your LVEDP, left ventricular end diastolic pressure.
And that pressure has to go somewhere.
It backs up, right into the pulmonary circulation, into the lungs. That's your flooded downtown.
Which is why patients get short of breath.
Exactly. That's dyspnea, or that very specific thing where they can't breathe lying down, orthopnea. If it's really bad, you listen with a stethoscope and you hear crackles.
Okay, so what about the right side? If the right ventricle is failing, the traffic jam moves into the suburbs.
Yeah, the suburbs are underwater. Right-sided failure means the pressure in the right atrium goes up. This causes all the systemic veins to have higher pressure.
And you can actually see this on a patient.
Oh, absolutely. You see it as peripheral edema, swollen legs. You see it as ascites, which is fluid in the abdomen. The liver gets congested and swollen, that classic nutmeg liver.
And the biggest sign?
The highest yield sign is looking at the neck for an elevated jugular venous pressure, or JVP. You can literally see the pressure backed up from the right heart.
So it's all about understanding why the pump is failing. Is it too weak or is it too stiff? That seems to be the core question.
That's the whole game.
Which brings us to how we actually classify heart failure. It's all about the ejection fraction, or EF. This one number tells you if the heart is a weak pump or a stiff house.
This is the absolute core of how we think about HF today. It's the first branch point.
Okay, so let's start with the first type.
First, you have HFrEF. That's heart failure with reduced ejection fraction. Some people call it systolic failure. The EF is 40% or less.
And the problem here is?
The problem is the squeeze. It's an issue of contractility. The muscle itself is just weak.
This is the stretched out balloon analogy, right? The ventricle is all dilated and floppy.
It is. It fills up with blood easily enough, but it just can't generate the force to eject it properly.
And on exam, you might hear an S3 gallop.
Yes, that sloshing in sound of blood rushing into an already overloaded, dilated chamber. And structurally, the change is called eccentric hypertrophy. The heart adds muscle fibers in series, which makes the chamber bigger and floppier.
Okay, so now let's compare that to the other side of the coin, HFpEF.
Right, HFpEF. Heart failure with preserved ejection fraction or diastolic failure. Here, the EF is 50% or more. So on paper, the squeeze looks okay.
Wait, okay. If the EF is preserved, why is the patient in failure? That sounds like a contradiction.
It is a contradiction.
Yeah.
And it's a brilliant question because it gets to the heart of the matter. The EF number is almost a distraction here.
So what's the real problem?
The real problem is stiffness. Decreased compliance. This is the rigid balloon. The ventricle is so stiff and thick that it can't relax properly to fill with blood.
I see. So even though it can squeeze out a normal percentage of blood,
The amount of blood it started with was too small to begin with because it couldn't fill properly. So the stroke volume is still terrible, but for a totally different reason.
and structurally, this is from concentric hypertrophy, the walls get thick because sarcomeres are added in parallel.
Exactly. Makes the chamber smaller and the muscles stiff. And the number one cause of that is long-standing uncontrolled hypertension.
The sources talk about visualizing this with pressure volume loops. Can you break that down for HFrEF first?
Sure. For HFrEF, the weak pump, the PV loop shifts down and to the right. It shifts down because the heart can't generate as much pressure.
Okay.
And it shifts to the right because the ventricle is dilated, so it holds a bigger volume at the end of systole and diastole. The end result is a much smaller stroke volume. It's operating on a flat Frank-Starling curve.
And for HFpEF, the stiff heart.
With HFpEF, the problem is pressure, not volume.
Yeah.
The diastolic filling curve is incredibly steep and shifted upward. It takes a sky-high pressure just to get a normal amount of blood into that stiff ventricle. The squeeze is fine, but the heart is fighting itself just to relax and fill.
So to summarize, HFrEF weak engine, often from a past heart attack. HFpEF rigid engine compartment, often from high blood pressure.
Couldn't have said it better myself.
All right, this next part is where the story gets, well, really destructive. When the heart's output drops for whatever reason, the body hits the panic button.
It sounds the fire alarm, the neurohormonal fire alarm system, and it just can't be turned off.
What gets activated?
Two major systems light up: the sympathetic nervous system, the SNS, and the renin-angiotensin-aldosterone system, or RAAS.
And at first, this seems like a good idea. The goal is to, increase heart rate, clamp down on blood vessels, and retain fluid to keep blood pressure up.
It's a great short-term fix. I mean, if you have sudden blood loss, this system saves your life.
But in chronic heart failure...
In chronic HF, it's poison. This persistent activation of RAS and the SNS is highly toxic to the heart. The chronic angiotensin II and aldosterone, they cause vasoconstriction, which increases afterload.
making the heart work even harder.
Exactly. And they directly cause fibrosis scarring and cell death within the heart muscle itself.
So these neurohormones are actually driving the ventricular remodeling. They're making the structural problem worse.
Correct. The sustained pressure and volume load from this cycle forces the heart to change its shape. For HFrEF, it drives more eccentric remodeling, more dilation. For HFpEF, it drives more concentric remodeling, more thickening.
It's a feedback loop from hell.
It really is. The natriuretic peptides, ANP and BNP, they get released when the heart's walls are stretched. So a high BNP level is a fantastic biomarker. It tells you directly how much wall stress there is, how much congestion.
So if your BNP is high, your heart is working way too hard.
Their stretch is high, your heart is crying for help.
Let's talk about what this looks like for the patient. The symptoms can be pretty non-specific at first: fatigue, maybe a little shortness of breath.
Yeah, and people often just chalk it up to getting older, but there are some really specific symptoms that point directly to those high cardiac pressures we've been talking about.
Like orthopnea.
Orthopnea is a huge red flag, dyspnea when lying flat. And if you think about it, it makes perfect sense. When you lie down, fluid from your legs redistributes back to the central circulation. That increases preload.
And a failing heart just can't handle that extra volume.
Can't handle it at all. So the pressure shoots up and backs into the lungs. That's when the patient tells you, I have to sleep on 3 pillows.
Or its cousin, PND, paroxysmal nocturnal dyspnea.
Right. Waking up in the middle of the night gasping for air.
Yeah.
It's the same mechanism, just slower. The fluid reabsorbs over hours of sleep until it becomes too much.
And then for the right side, you've got the bilateral pitting edema and that elevated JVP. It's the pressure backing up that you can actually see and touch.
It is. It's the high right atrial pressure made manifest.
Okay, let's revisit those classic heart sounds, S3 and S4. because they're like a diagnostic shortcut.
They really are.
Yeah.
The S3 gallop sounds like sloshing in. That's the sound of blood rushing into a dilated, volume-overloaded ventricle.
A floppy ventricle.
A floppy, overstretched ventricle. It's the hallmark sound of HFrEF, of systolic dysfunction.
And the S4 gallop.
The S4 is the opposite. That's the sound of the atrium contracting forcefully against a stiff, non-compliant ventricle. It's fighting to push blood in.
So that's your HFpEF sound.
That is the characteristic sound of diastolic dysfunction, almost always from chronic hypertension.
And then finally, we grade the severity with the NYHA classification.
Right, which is really just a way to standardize how limited someone's physical activity is. It's about their quality of life.
The sources use a simple car analogy for this.
Yeah, it's easy to remember. Class 1, no limitation. Your car runs perfectly fine.
Class 2.
Class 2, you get symptoms with ordinary activity, like climbing stairs. The car runs, but it struggles going up a hill.
Class 3 is a big step down.
Big step. Symptoms with minimal exertion, like just walking across a room. The car can barely make it out of the driveway.
And Class 4 is the end stage.
Symptoms at rest. The car cannot run at all. This is an emergency.
Okay, let's shift to etiology. Knowing the cause is everything. Let's run through the highest yield causes for each type.
For HFrEF, the #1 cause, by far, is ischemic cardiomyopathy, weakness from past heart attacks. On an echo, you'll see regional wall motion problems.
And you can have non-ischemic causes too.
Of course. That's dilated cardiomyopathy, or DCM. The heart is globally weak, severely dilated. Think chronic heavy alcohol use, viral infections. Sometimes it's genetic.
And for HFpEF, we already said it's mostly about pressure.
Overwhelmingly, it's hypertensive heart disease. But you always have to keep the infiltrative diseases in mind, like restrictive cardiomyopathy. Amyloidosis is the one to know.
Right, where amyloid protein deposits in the heart, making it incredibly stiff.
Exactly. It acts like a super severe form of HFTCF.
And there's that classic clinical pearl for amyloid.
Yes, the big paradox. On an ultrasound, the heart walls are super thick. But when you do an ECG, you get low voltage.
Low voltage ECG despite thick walls.
That combination is almost pathognomonic. It's a key piece of pattern recognition.
Okay.
Hypertensive heart disease,
Yeah.
the textbook cause of HFpEF.
This is a pure pressure problem. Years and years of high afterload force, that concentric hypertrophy we talked about. You get a stiff, thick-walled heart, diastolic dysfunction.
And the clinical picture is classic.
Oh, it's a board exam question for a reason. An elderly patient, long history of poorly controlled hypertension, you hear an S4 gallop, and the echo shows a thick wall, but a preserved EF. That's the vignette.
But there's another crucial cause of HFpEF we have to talk about, the infiltrative cardiomyopathies.
Yes, restrictive cardiomyopathy, or RCM. Here, the ventricles are stiff not because they're thick from pressure, but because something has physically infiltrated the muscle. It feels like a rock.
What are the big ones to know? Let's start with amyloidosis.
Amyloidosis is key. So you have a patient with HF symptoms, and their echo shows a really thick ventricular wall.
Okay, sounds like hypertrophy.
Right, but then you look at their EKG, and it shows low-voltage QRS complexes.
Wait, so a thick wall but low electrical signal? That's a mismatch.
A huge red flag. That's the amyloid protein infiltrating the heart. It adds bulk, but it doesn't conduct electricity. You should also look for other clues, like carpal tunnel syndrome or neuropathy.
Got it. And what about hemochromatosis?
That's iron overload. The iron deposits in the heart muscle and can cause a restrictive picture. You look for the other signs, that bronze skin, new onset diabetes, and often really nasty conduction system problems.
And in advanced cases, you can get things like Kussmaul's sign.
Absolutely.
Oh, there.
The jugular venous pressure actually goes up when they breathe in because the rigid ventricles just can't accept any more volume.
Okay, we've covered a lot of ground. Let's shift to a couple of really important exam traps, starting with a total paradox. High output heart failure. How can you be in failure if your cardiac output is high?
It's a great question because it feels so counterintuitive. In high-output heart failure, the CO is, in fact, elevated. The heart is working overtime.
So what's the problem?
The problem is that the body's metabolic demand is even higher, or the peripheral resistance is so low that even that hyperdynamic output isn't enough to perfuse the tissues properly. The heart just burns out trying to keep up.
So the patient has all the classic signs of failure edema, shortness of breath, but the physical exam is totally different.
Completely the opposite of cardiogenic shock. Instead of cool and clammy, their extremities are warm, they have bounding pulses, a wide pulse pressure. It's a hyperdynamic circulation.
What causes it?
There's a good mnemonic,
Okay.
a THUP, anemia, thyrotoxicosis, AV shunts and Paget's disease.
The AV shunt one is a great example, like in a dialysis patient.
Perfect example. A large AV fistula bypasses all the high-resistance capillaries.
Hmm.
Systemic vascular resistance plummets, venous return skyrockets, and the heart has to pump like mad to compensate. It's just mechanical exhaustion.
Okay, another trigger, arrhythmia.
Yeah.
Tachycardia-induced cardiomyopathy is fascinating because it's reversible.
It's one of the few forms of HFrEF that can be. If you have a heart rate that's just stuck above, say, 100 for weeks or months, the heart never has time to fill properly.
So it develops a dysfunction that looks just like a dilated cardiomyopathy.
Exactly. But if you can control that rate, get them back into a normal rhythm, a lot of that LV function can actually come back. It's critical to recognize.
And what about the opposite problem, losing the atrial kick?
Ah, that's crucial, especially in those stiff HFpEF hearts we talked about. That last little squeeze from the atria might account for 30% of their cardiac output.
So if they suddenly go into atrial fibrillation?
They lose that kick instantly, and for a stiff ventricle that absolutely depends on it, that's catastrophic. It can trigger acute decompensation, flash pulmonary edema, just like that.
And just to tie it all together, what about valves? Acute memoir?
Yep. Post-MI, a papillary muscle ruptures. Blood suddenly surges back into a left atrium that hasn't had time to stretch. The pressure spike is immediate and massive. Flash pulmonary edema.
And aortic stenosis.
AS is the model for pressure overload. It causes that profound concentric hypertrophy, which is the very definition of the pathophysiology of HFpEF. The D in the SAD triad dyspnea is pure diastolic dysfunction.
Wow. So if we were to synthesize all of this,
Yeah.
what's the one big takeaway?
The biggest takeaway is that heart failure isn't a single event. It's a cascade. It starts with a mechanical problem, a floppy pump or a stiff container that triggers this relentless, chronic, self-destructive neurohormonal response.
The RAS and SNS overdrive.
Right. And that response is what causes the structural remodeling, the thickening or the dilation that just locks the patient into a downward spiral.
And for you, the learner, understanding that cascade is the key to understanding the treatments. You now know why we use drugs like ACE inhibitors and beta blockers.
You're not just treating symptoms, you're trying to break that vicious cycle of self-sabotage.
Which brings us to our final provocative thought for you to mull over. We talked about ischemic cardiomyopathy, where muscle is replaced by scar. Now think about this. For patients with severe HFrEF, with an EF below 35%, we put in defibrillators, ICDs. Those devices don't help the heart pump. They're there to shock it out of a fatal arrhythmia.
So consider this. That structural remodeling, that scar tissue you just learned about, isn't just a mechanical problem. It's the literal electrical circuit for ventricular tachycardia. The mechanical failure directly creates the electrical instability that can kill the patient. Think about how structure and rhythm are just fundamentally and fatally linked.